So welcome to everyone. Thanks so much for joining this fourth masterclass organized by the International Ocular Circulation Society. We are very honored that Professor Robert Linsenmeier accepted our invitation today and serves as a lecturer in this masterclass series. Rob Linsenmeier is Professor Emeritus of Biomedical Engineering and Neurobiology at Northwestern University in Chicago. His research focuses on the microenvironment of the mammalian retina, including oxygen and pH regulation in health and disease, for which he is a world-renowned expert. He's also very active in education research and set up, for instance, the Northwestern Center for Engineering Education Research. He is editor-in-chief of the journal Current Eye Research and fellow of the American Institute for Medical and Biological Engineering. So without further ado, let's welcome Professor Linsenmeier to give his lecture on ocular oxygenation from physiology to clinical implications. Please, Professor Linsenmeier.
Thanks very much, Andreas. Waiting for the slides to pop up here. Yeah, so can you see the slides? Huh. Okay, so you can see the slides now, right?
They're still waiting for something. Maybe you need to do full screen mode, it says. Oh, perfect. Now we see it.
Right, so I've been tasked by IOCS with talking about ocular oxygenation. To me, that really means retinal oxygenation, and we're going to confine our attention to that. And I'll talk both about the physiology and a little bit, at least, about some of the clinical implications that I see as part of this story. We're going to talk a little bit about oxygen measurements in humans, but very briefly. Then most of the talk will be about oxygen measurements of retinal oxygenation in animals. But these, we think, apply very directly to oxygenation in humans. We'll talk about PO2 and metabolism in the outer retina and then the inner retina. We'll talk briefly about systemic hypoxia, and then I'll talk a little bit about three clinical situations that we've worked on. And I should also thank a few people. One is IOCS for allowing me to put this all together. One is the National Institutes of Health, which have funded this work for about 40 years. And the last thanks is to all the people who have been through my lab, who have contributed to lots of these things that I'm going to talk about. Too many to actually mention. So to start with the human retina, the way oxygen is usually measured in the human retina, not absolutely the only method, but the major method is by reflectance oximetry. And there are several types of retinal oximetry. I am not at all an expert on this, and so that could be the subject of another whole lecture. But all of these methods rely on the difference in absorption or reflection of light by hemoglobin and the difference between oxygenated hemoglobin and deoxyhemoglobin. So the curves for this are shown to the left here. If hemoglobin is deoxygenated, it has this relatively simple curve. If it's oxygenated 100%, then it has this red curve. And what you have to do is to compare at least one wavelength where the two curves are different, the reflections from those two at that wavelength. And you have to compare it to at least one wavelength where there is no effect of oxygen. This would be a two wavelength method, but many methods use multiple wavelengths. But they all result in a map very much like the one shown at the right, where the red and yellow indicate arterioles with high arterial saturation, with high oxygen saturation. And the green and yellow represent venules with much lower saturation. The first measurements of this kind were done in the late 1960s, but people have worked on it ever since then. And it might seem relatively simple, but in fact, there's lots of complications to this method. And so it still requires ongoing work. There are just a few things that I can say to show how this has been used. One is to look at what happens during breathing of 100% oxygen. And what you see here is that, as I said, the arterial saturation is high and the venous saturation is around 50 or 55%. When you breathe oxygen, the venous value goes up, but of course, the arterial value, which was mostly saturated to begin with, hardly changes. Now, this could mean that the retina is actually using less oxygen when a person is breathing 100% oxygen, but that's probably not true. It's extracting less from the retinal circulation, but metabolism, as far as we know, is very much the same. So that kind of illustrates the possible confusions that you could have with oximetry. A simpler case would be venous occlusion, where when when central retinal vein is occluded, and the blood is static in the veins, the saturation is considerably lower. So that certainly makes sense. A number of people have tried to understand what happens in diabetic retinopathy. So here's a figure that comes from work by Jorgensen and Beck, but Stephenson's group has found similar effects. The venous saturation goes up in diabetic retinopathy, both early and then in proliferative retinopathy. And in this case, the venous saturation is probably going up because the retina is using less oxygen. But there are several limitations of oximetry, and I just wanted to mention those. The calibrations are very difficult, so there's really no ground truth. You don't have a reference value to compare these two. The reflectance of the background is one of the big complications. It can influence the measurements. This can only be done for larger retinal vessels. People have tried to do this for capillaries, but it's not clear that those are successful. And of course, it can't evaluate the oxygenation in the tissue outside the vessels because there's no hemoglobin there. Of course, it's also confined to the inner retina where the retinal circulation is, so you get no information about the choroid or the outer retina. And you can measure oxygen consumption by using oximetry if you combine it with blood flow. And there have been a few studies that have now done that. But even when you do that, you get only the global measurement for the entire inner retina. And as I showed you with hyperoxia, with only saturation measurements, interpretations of deviations from normal can be complicated unless you know something else about the system. So some of those can be addressed, at least in part, and that's what the work over the last 50 or 60 years has done. But it's still mainly a research tool and not yet a clinical tool that is used in regular practice. What we've done is completely different. My lab has, and only one or two other labs in the world, have measured intraretinal PO2 from animals in vivo. We've done this in cats, macaques, and in rats. These are anesthetized animals that are sacrificed at the end of the experiment. The animals are paralyzed and artificially respirated, and that's important because it allows us to control the PO2, PCO2, pH, and glucose and keep them in the normal range so that we know that the situations are physiological. Most of our measurements are made under dark adapted conditions, but I'll talk a little bit about the effects of light as well. We make these measurements with double-barreled microelectrodes. This is very important to us. One barrel of the electrode has gold at the tip, and oxygen is reduced at this surface. So the current that's produced is proportional to the amount of oxygen that's actually available at the tip of the electrode. And we have basically 1 micron spatial resolution with this electrode. They're also very fast. The other barrel of the electrode measures the electroretinogram so that when we put these inside the retina, we can verify the position because we know how the electroretinogram changes with depth in the retina. So here's kind of our basic picture of oxygen across the retinal depth. What we do with the microelectrode is penetrate the retina in steps, and we check the ERG as we're going along. Then we gradually withdraw the electrode, and what that does is to generate this profile of PO2 across the retinal layers, as is shown at the top. This happens to be a cat retina. And so the profile in the dark adapted retina has several characteristic features. It has a relatively high choroidal PO2, a steep gradient into the retina from the choroid, a shallower gradient from the inner retina to the photoreceptor inner segments, where all the mitochondria are, as shown here in green. And because the metabolism there is very high, the PO2s at that region are quite low. That's true in cats and monkeys, at least. These peaks in the inner retina tell us that we're somewhere near a capillary. These are relative sources, but we don't know that we're actually at a capillary because we're in dark adaptation, and we also couldn't see the tip of the electrode even if we wanted to because it's too small. So I'll talk a lot about the differences between the outer retina, which is the avascular part of the retina consisting largely of photoreceptors, and then the inner retina. And it turns out that the border between the avascular and vascularized retina is just about halfway through the retina. This is true in cats as well as people, and it's true across the entire retina, except, of course, for the fovea. I need to take you through one math slide, just briefly. What we do with the outer retina is to fit a diffusion model to it. And the diffusion model is very simple. It's one-dimensional, steady-state diffusion. It has a solution whose general form is here, which involves the consumption of oxygen. And we discovered a long time ago that there were 3 layers in the model that corresponds to reality. And the interpretation of this profile is that if there's a straight line, that means that this first term in the solution is 0, so there's no consumption. If the curve is concave, that means that there is consumption that's greater than 0. Now, this analysis only works because the outer retina is avascular. So, except under special conditions, it does not work at all for the inner retina. So the profiles are linear in layers 1 and 3, corresponding to the outer segments and the outer nuclear layer. So there's no oxygen consumption in those layers. but they have a quadratic shape in layer 2. So this is where all the oxygen is used in the outer retina. Now, what's important about this is that it allows us to extract values for photoreceptor oxygen consumption in vivo, which is pretty hard in any other way. We have similar profiles in monkeys and in cats and in rats. The average PO2 at the choroid, PC here, across lots of experiments and lots of profiles, is actually 47. So these actually show PO2s that are unusually high. But there is a lot of variability in choroidal PO2. And in darkness, what the model allows us to do is to say that there's 80% of the oxygen for the photoreceptors that comes down this gradient from the choroid, and only 10 to 20% that comes from the retinal circulation down this shallower gradient. That 10 to 20% is probably quite important, but most of the oxygen for the photoreceptors comes from the choroid. Now, what happens if you turn on a light? Well, the main thing that happens is that the PO2 around the inner segments goes up. So here's a monkey profile in dark adaptation and one in light adaptation, and you can see that the PO2 is higher here, that I've shown by this little purple bar. The same thing happens in the cat. And a higher PO2 implies that less oxygen is being used, more is left over in the retina. So in light adaptation, the oxygen utilization of the photoreceptors is lower. Sometimes, as is shown in this light adapted profile from cat, choroidal oxygen diffuses all the way to the inner retina. You may be wondering what's going on in the fovea where there is no retinal circulation. It's been very hard for us to make measurements in the center of the fovea because, again, we can't see exactly where the tip of the electrode is, and it's going in on an angle. But under the best conditions, we can see that the outer nuclear layer, which would be the inner part of the retina in the fovea, has a relatively flat and linear profile. Occasionally, a little bit of oxygen comes in from the vitreous. But fundamentally, the photoreceptors are behaving the same way. The PO2s are going up in light, and so the consumption is going down. But we know a lot less about the fovea than we do about regions outside of it. So what we know about the outer retina is that 80 to 90% of the photoreceptor oxygen comes from the choroid. And using the model, we've been able to say that the oxygen consumption of the outer retina is 3 to 4 milliliters per 100 grams per minute in darkness. That's not a remarkably high number. It's very similar to what you would have in the brain. That's if we take the whole outer retina and sort of assume that the oxygen consumption is distributed over the outer retina. But of course it's not. It's confined to the inner segments. So what's unusual about the outer retina is not the total amount of oxygen it uses, but that oxygen consumption is concentrated in the inner segments. Now, there is also oxygen consumption in the photoreceptor synapses, but these are in the outer plexiform layer, which is a vascularized area. So our models don't actually account for that. Light reduces oxygen consumption to something like 50% to 70% of the dark value. It's always lower in the light. And occasionally, or sometimes, all of the oxygen supplied to the photoreceptors seems to come from the choroid, with a little left over to go to the inner retina. The diffusion equations also provide the basis for simulations, which I'll show you in a little while. So turning to the inner retina, we can look again at these profiles. Again, there's no good mathematical model for the inner retina, and the PO2 in the inner retina is quite variable. So how are we going to deal with it? I can emphasize the variability again by showing you these profiles from the rat retina, which were made in adjacent places in the retina. We moved the electrode and did a profile 150 microns away. So these are separated by 150 microns in the lateral direction. And sometimes you see one peak in the inner retina, as in these top profiles. Sometimes you see two peaks. Sometimes you don't really see any peaks at all. Sometimes the oxygen is diffusing toward the vitreous. Sometimes it's diffusing from the vitreous into the retina. So the inner retina is very complicated. And one thing we can do with it is we can generate histograms of the frequency with which we see different PO2s. So I'm showing you here one of those histograms. This is a histogram from 36 profiles in several cats. I don't remember how many. So this is the frequency on the ordinate and the PO2 on the abscissa. The average here is 18.4 millimeters of mercury, but the PO2s cover a very wide range. So there's no single normal PO2 in the inner retina. It depends very much on how close the tissue is to a capillary. And so presumably all of these are normal. Now, when you turn on the light, you see a similar distribution. This is with steady light at about rod saturation. So it's enough to completely saturate the rod system. And the inner retina now has an average PO2 of a little less than 13 millimeters of mercury. But again, it's quite variable, and you could have any PO2, almost any PO2. Sometimes when you turn on a light, you can actually see the decrease in PO2 from darkness. These fluctuations that you see here are respiratory fluctuations. But you can't always see this. Sometimes when you turn on a light and you have the electrode stationary in the inner retina, nothing actually changes. Well, what about oxygen utilization in the light? Well, as far as we know, there's no effect of steady light on inner retinal oxygen consumption, or what we call Q inner retina. Now, it's, as I mentioned, the model doesn't actually work for the inner retina, except under special conditions. And I don't really have time to talk about those conditions, but I can explain them later if you want. But our work, which was done on isolated mouse retina and on cat retina, and these three other studies on rat and pig, all indicate that there's really no difference in oxygen consumption in steady light as there is in darkness. The ratios are very close to 1. So while the PO2s may be a little lower, that doesn't seem to affect oxygen utilization. Flickering light, however, is different. These were done in the isolated mouse retina so that we could separate the effects of metabolism from the effects of changes in blood flow, both of which could affect the PO2. So here we're looking purely at the effects of metabolism on PO2. And in the outer retina, so this is traces made with the electrode stationary at these different depths in the retina. So if you look at the outer retina, as we talked about before, the PO2 goes up when you turn on a light. In this case, it's flickering light. That indicates that the consumption is going down. If you look at the inner retina, now you clearly see a decrease in PO2, indicating that the oxygen consumption is going up. If you look across a bunch of different mouse retina preparations, again, the outer retinal oxygen consumption goes down by about 25% in this case. The inner retinal oxygen consumption goes up by about 6%. So it's much smaller. It's also faster if you look at the time course of these curves. Inner retinal response in terms of oxygen is faster than in the outer retina. Now, these had to be relatively modest amounts of light because in isolated retina, we did not have a retinal pigment epithelium, so we couldn't have regeneration of the pigment. But at the end of experiments, we sometimes used a brighter light to see what it would do. And the calculations indicate that with a brighter light, you can have an increase in inner retinal consumption of about 30%. And these increases in consumption are undoubtedly the metabolic change that drives neurovascular coupling, which is that the increased metabolism drives an increase in blood flow. But these are really the only measurements of inner retinal consumption during flicker. So if we try to summarize the inner retina, there's an average PO2 of around 18 millimeters of mercury in the dark. It's a little bit lower in the light, but again, it's extremely variable. So there's really no normal value. As I mentioned, the oxygen consumption of the inner retina is the same in darkness and in steady light, but flickering light increases oxygen consumption in the inner retina. This is all in contrast to the outer retina, where steady and flickering light both decrease oxygen consumption by about the same amount. The inner retina behaves quite differently with respect to light. What I haven't shown you is that the inner and outer retina use about the same amount of oxygen. There's many measurements of that, and it is not always recognized. People think the photoreceptors use a lot of oxygen. The inner retina doesn't use so much oxygen. But really, the two halves of the retina are very well matched in the amount of oxygen they actually use. I wanted to say just a couple of words about hypoxia. These are profiles in the dark adapted cat retina and the light adapted cat retina. And what I want you to pay attention to is that the choroidal PO2 is going down as we add nitrogen to the breathing mixture and lower the arterial PO2. So the choroidal PO2 is unregulated and just decreases as the arterial PO2 decreases. In the inner retina, there's very good regulation of PO2. So here's that histogram that I showed you before, which is under normal normoxic conditions, where the arterial PO2 is greater than 85 millimeters of mercury. For arterial PO2s between 60 and 85, it really doesn't look any different. It begins to look different when arterial PO2 goes below 60. So this is between 45 and 60 millimeters of mercury. And then finally, below 45 millimeters of mercury, you see a loss of these higher PO2s, and the average pretty clearly shifts. But the inner retinal PO2 is very well regulated in a normal animal during hypoxia. So let's talk a little bit about what happens in some clinical situations. And we'll start with diabetes. So we know from human studies that there must be hypoxia late in diabetic retinopathy. No intraretinal measurements have ever been made, but we know that if there's capillary closure, there must be hypoxia because the retinal circulation has no redundancy. If you lose a capillary, nothing is going to replace its function. And choroidal oxygen doesn't make it to the inner retina. There's also measurements that show lower vitreal PO2 that have been measured during vitrectomy in proliferative diabetic retinopathy. And that's what we know about humans. Our measurements, however, are the only ones of intraretinal PO2 in diabetes. And we started with cats. We had an opportunity to record oxygen levels in 3 pancreatectomized cats that had long-term diabetes. You have to pancreatectomize them. The drugs that destroy beta cells in the pancreas don't actually work in cats, so you have to take out the whole pancreas, which makes these cats very difficult to manage. But Diane Hatchell at the Duke University Ophthalmology Department, in collaboration with a veterinarian at the Durham, North Carolina VA hospital, managed to raise these cats successfully for a number of years. And then they shipped them up to Evanston where we made measurements. These animals did exhibit background diabetic retinopathy, including microaneurysms, fluorescein leakage, and at least some capillary loss. But it took a long time. So what did the oxygen environment of these animals look like? Well, here's a normal profile at the top, but many of these animals had no oxygen in the inner retina. As you can see, the profiles are quite flat. Sometimes, sometimes there is a peak in the inner retina, indicating that not all the blood vessels are gone. Blood vessels, the oxygen level is provided to some extent by the retinal circulation. But a lot of these profiles look very abnormal. If we look at a histogram from the diabetic animals, it's shifted to the left relative to the normal cats down here at the bottom. And then we were able to send these eyes to our colleagues Jerry Luddy and Scott McLeod at Hopkins, and they did histology of the retinas and were able to identify the regions where we had made microelectrode penetrations. And what they saw were microaneurysms, adherent leukocytes in capillary venules, microaneurysms with adherent platelets and damaged endothelia, as well as acellular capillaries with thickened basement membrane. So we know that in areas with vascular abnormalities, we are certainly seeing some hypoxia. But cats are not a sustainable model to study diabetes. We were able to get very few animals. They were expensive and difficult to maintain. And diabetic retinopathy develops extremely slowly, as it does, of course, in humans. So we were left with the question whether there was hypoxia earlier in the diabetic retinopathy, as the VEGF studies had shown in people. And if so, when did that occur? So there was this suggestive evidence of early hypoxia in humans. VEGF is elevated even in background retinopathy. And we know that VEGF is controlled at least partially by hypoxia-inducible factor. It is controlled by other things, and that's not often recognized. But hypoxia-inducible factor is one of the main controls of it. And there's this intriguing result that hyperoxia improves contrast sensitivity in humans with background retinopathy. And it doesn't do that in normal humans. So that suggests that the retina must have been a little hypoxic before the hyperoxia. Otherwise, hyperoxia would not have had any effect. So there is this evidence that that there's hypoxia before we actually see major vascular problems. So we switched to using streptozotocin-treated diabetic rats because that allowed us to track PO2 over time. And there are many indications that these rats have signs of diabetic retinopathy. There are molecular changes. There is leakage that many groups have reported. There's some capillary loss. And we ourselves have seen ERG changes and ganglion cell loss, which other groups have also reported. So what we were able to do was to then measure the PO2 in the retina in animals with 6 or 9 or 12 months of diabetes. Now, these animals, these rats, unlike cats, the rats have very prominent cataracts. So even if we wanted to be able to see in the eye, we would not be able to. So the ERGs were extremely important in these animals in being able to tell where we were in the retina. And we couldn't direct the electrode to any particular location. We had to just take what we got. So these are severely hyperglycemic animals. We had a group of 6-month diabetic long Evans rats, a group of 12-month diabetic long Evans rats, and a group of brown Norway rats, which we did just to make sure that long Evans rats weren't special. And as you can see from the glucose measurements in the blood, they were all severely hyperglycemic, and they were also much smaller than control rats of the same age. So what we did was to measure profiles and find the average intraretinal PO2 in each profile, and then do an average for each rat. And here are the results for 6-month rats. Each dot is an animal. Green dots are control animals, and red dots are diabetic animals. You might say that the diabetics were lower, but statistically, there is no difference between these groups. And we suspected that for a couple of these animals, the calibration that we had done in vitro did not actually hold in vivo. We were unable to recalibrate the electrode at the end of the experiment in those cases. And so what we decided to do was to normalize the intraretinal PO2 by the choroidal PO2, because the choroid is not thought to be as affected by diabetes as the inner retina. And when we did that, there's obviously no difference between the controls and the diabetics. And the same thing is really true after 12 months of diabetes. No clear evidence of hypoxia, even after a year of very poorly controlled diabetes. Now, there's another way to look at this, and that is to look at the shape of the profiles. Because, of course, if there's occlusion of the circulation in the inner retina, you will lose these peaks. But as I've already showed you from the rat profiles, you sometimes see profiles that don't show any clear evidence of circulation in the inner retina, even in normal animals. So that's what we saw. Here is poor retinal circulation or absence of retinal circulation in control animals and in diabetic animals. And the proportion with poor circulation was not different in diabetics versus age-matched controls. And this is true in the brown Norways and in the long Evans rats. So we could really not find any evidence of generalized hypoxia. So in areas with vascular abnormalities, that we could identify, microaneurysms or adherent leukocytes, those areas were hypoxic in cats and probably are in humans. But there's no evidence of generalized hypoxia in rats maintained as long as 12 months with very poor glucose control. So why is there no clear hypoxia in the rat? Well, we don't really know. Rats could be different. Some of the basement membrane, there is some basement membrane thickening and some capillary loss, but of course there's never proliferative retinopathy. It could be that we missed regions that were affected because we couldn't identify regions as we could in cat, and because the cataracts prevented that even if we tried to see in the eye. I wanted to spend a minute talking about retinal detachment because it seems like with the choroid separated from the retina, that there should be an effect on the oxygenation of the photoreceptors. We studied this first with simulations using our mathematical model. So the curves here are for the outer retina only. They have this characteristic shape that we've seen now. And the red curve is for an attached retina, where we're going to call the oxygen consumption 100%. If you only detach the retina by 100 microns, shown by this little purple bar, then you have 100 microns of fluid under the retina. And the modeling indicates that oxygen consumption goes down to about 34% of normal. You cannot maintain it better than that. And if the detachment is 500 microns, then you've got more fluid under the retina. This is still not a very large detachment, but you have only 15% of the normal oxygen consumption of the photoreceptors. And the reason for this is that you have a shallower gradient and a smaller flux, so not enough oxygen actually reaches the photoreceptor to sustain normal metabolism. And the numbers are this high, actually, mainly because we're assuming that in the inner retina, the retinal circulation rides along with the detachment and is functionally normal. So the situation could actually be worse if the retinal circulation is compromised as well. So we thought that choroidal PO2, which increases dramatically in hyperoxia, might help the situation. So this is choroidal PO2 as a function of inspired oxygen from several studies. And you can see that as inspired oxygen increases, the choroidal PO2 goes way up. It's fully saturated before that with oxygen, but it's the PO2 that's driving oxygen into the retina. And so it tends to continue to increase. So again, we did the simulation, and with the choroidal PO2 much higher, the oxygen consumption could be much better maintained. Then we did some experiments, and I'll call your attention to the choroidal PO2 or choriocapillaris PO2 at the back of the retina. Now we have a fluid layer under the retina. This fluid layer is only 250 microns thick, but the PO2 at the back of the photoreceptors is considerably lower. Whereas if we allow the animal to breathe 100% oxygen, PO2 at the choroid goes way up, so the PO2 at the back of the photoreceptors can be maintained as well. In this particular case, we must have been fairly close to a larger artery in the retinal circulation, but it's the choroidal PO2 that I'm calling your attention to. So what about the consumption? Well, let's just look at the right here. will call the oxygen consumption of the photoreceptor as 100% or 1 when the retina is attached and the animal is air breathing. If you detach the retina, it falls to about half, even though these detachments are relatively small. If you breathe oxygen, or if you allow the animal to breathe oxygen, rather, the consumption goes up. So the outer retinal oxygen consumption is much lower during detachment, during air breathing, but hyperoxia maintains it at something like 68% of normal, which is significantly better than air breathing. We also know that if you allow animals, cats, to breathe 70% oxygen for 3 days after a detachment, that you can save photoreceptors. There's less photoreceptor apoptosis. That was shown in a study by Mervyn et al. In 1999 from Jonathan Stone's group in Australia. So in retinal detachment, the photoreceptor metabolism is reduced because the critical supply from the choroid is reduced, but hyperoxia can maintain photoreceptor metabolism at much higher levels than air breathing by increasing the flux from actually both the retinal and choroidal circulation. With no treatment, you do lose some photoreceptors. So we actually think it would be a good idea to treat people with oxygen while they're waiting for reattachment surgery, especially if the macula is detached. So I think I've pretty much run out of time. Let me see if I should give this last little section or whether we should stop at this point.
I think we can go a little bit further, Dr. Linsenmeier.
Okay, so let me talk about retinal artery occlusion, which is one of the other things that I wanted to talk about. So with retinal artery occlusion, there is no effective treatment that is used at this point. But we wanted to know what the PO2 gradient was across the retina and whether hyperoxia would be helpful in this case. There might be some disadvantages of using hyperoxia, but we wanted to do this investigation. So what we did was to occlude a retinal arteriole at the disc with a glass probe so that it would be a reversible occlusion. And then we made profile measurements as usual. And what you can see is that during occlusion, as you would expect, there is no oxygen in the inner retina. Whereas if an animal breathed oxygen, 100% oxygen, again, the choroidal PO2 goes way up and you can drive oxygen much further into the retina. So is this actually beneficial? Well, the answer to that is yes. With a retinal occlusion, when the animal is air breathing, you pretty much lose the B wave. This is B wave amplitude under these 3 conditions. So you pretty much lose the B wave if the animal is breathing air during the occlusion, and it's restored to, on the average, about 50% if the animal breathes oxygen. So it is clearly beneficial, at least in animals. So might hyperoxia actually help? Well, yeah. One of the other questions is that we need to know how long the retina can still recover after an occlusive episode. And Hayra's group showed in monkeys that this was at least 100 minutes. And we've also done similar experiments and find the same thing. This is much longer than you have to restore function in the brain, partially because there is some oxygen and some glucose out here in the vitreous that can do vegetative metabolism in the inner retina. but hyperoxia will clearly get more oxygen into the retina. Could you use it indefinitely? No. There are toxicity issues with 100% oxygen, but vessels often open up, so you don't really need to use it for extended periods of time. You just need to do it until the circulation fixes itself. So here are curves, again, from the modeling under air breathing, where there's no oxygen in the inner retina. And then with 100% oxygen, we calculate that you can get back about 80% of the metabolism of the inner retina with 100% oxygen. You might need a little more than 100% oxygen to get oxygen consumption to be 100% normal, but you don't actually need hyperbaric oxygen. You have to breathe 100% oxygen. You can't just use a nasal cannula. Even with a nasal cannula running oxygen at a pretty high rate, it's still mixing with air. So the PO2s are roughly 100, not 200. But this high intraretinal PO2 only lasts as long as the hyperoxia is maintained. It will go back to normal if you remove the hyperoxia, and it'll change within 1 or 2 minutes. So what I wanted to say is that the inner retina is anoxic. The retina can survive probably at least 2 hours in this state, possibly longer in some sort of vegetative state. Hyperoxia can supply the retina, and hyperbaric oxygen is likely not better than 100%. We actually modeled that, but I'm not showing you that. There are some concerns with hyperoxia related to toxicity and ischemia reperfusion injury, and you often don't know how long your patient has had an occlusion. But without treatment, part of the retina will die. Now, there has been some prior research on hyperoxia for arterial occlusion, and it has mixed results. But no clinical trial has yet fully understood the oxygen environment of the retina in order to optimize the treatment. So we think there's room for improvement. So that's where I will leave you and stop sharing.
Thank you so much, Dr. Linsenmeier. This was fantastic. I learned so much. It was, I mean, time passed by. I can't believe that it's 1 hour already. So, yeah, so I think you highlighted beautiful the different diseases, clinically relevant diseases, diabetes, retinal detachment, the vessel occlusions, and you also showed the role of oxygenation in these diseases. So I have one particular question regarding detachment. So because you nicely showed the effect of detachment on oxygenation, but what is the effect of duration of detachment? So in other words, if the detachment kind of continues for a certain period of time, do we see changes in oxygenation in these cases? So in other words, does oxygenation change during time?
Yeah, that's a good question. The detachments that we were able to make were acute detachments. So we were making measurements, within an hour or 2 after the detachment, and we could not do the reattachment to see what happened then. There are many changes that happen in the photoreceptors. They withdraw their outer segments. They detach at the outer plexiform layer. So they tend to reduce their metabolism by trying to preserve their function. And so the metabolism goes down in photoreceptors. And so then the situation isn't quite as bad. But they're continuing to die all the time. But I expect that if we were to be able to make measurements after a day or two of detachment, the oxygen profiles would look a little different, and the metabolism would be down, but that would be okay for the photoreceptors that existed at that time.
Okay.
It's pretty tough to measure it.
Okay. So I also remember, I'd like to remember all the audience to post questions in the Q&A, and I will then ask Dr. Linsenmeier these questions. So please just put your questions in the chat. And I think, Dr. Beach, you have a question to Dr. Linsenmeier, right? I think you're muted.
I'm
yeah.
muted. Oh, I think I'm unmuted now. Do you hear me? Yes.
Yes.
Well, just a little bit of here on the reflectance technique for looking at relative saturation in human retina, perhaps clinically, perhaps in research. Yes, there really isn't a ground truth that we can rely on to make even compare relative measurements. It's very difficult. What we did in the past, in a very early study, was with diabetic subjects who did not have retinopathy yet. We did this at University of Virginia. And the subjects were taken care of very well by the diabetologist who was part of the study. And we found that with them, we got quite a large signal in the reflectance from retinal vein following an oxygen challenge, that is during acute hyperglycemia, that was compared with prior to the oxygen challenge. So we have here a case where the subjects are their own control. And that's one of the areas where I think clinical application could begin with a technique like this reflectance, which is pretty non-invasive. Otherwise, yes, you do have problems. You also have problems with the pigmentation and different subjects and, in different racial profiles of pigmentation. And perhaps using their own, doing an A/B measurement, whether their own control can also make that work. And finally, we have seen coming out of Toki Beck's lab some use of ribosol velocimetry Doppler on individual vessels to give some regional centerline velocity. Maybe it can be adjusted for blood flow. And I'm thinking if those can be combined with regional vessel segment saturation measurements, there could be some surprising new results from that. That's all I wanted to bring up at this point, and not delay further questions. What do you think, Robert?
I don't see any further questions in the chat, so I'm happy to comment on those points. I completely agree that using a subject as their own control or tracking things over time, either with a manipulation or with a treatment, then oximetry does have some utilization and some advantages that could be clinically important. In our own studies with microelectrodes, we do actually better when we can compare a cat and a retina to itself also than when we are given a group of animals with diabetes and have to compare it to another group without diabetes. So these manipulations within a person or an animal, I think those are that's a great idea, and people doing oximetry should focus on those and pursue those.
We have a couple of questions from the audience, Dr. Linsenmeier, so we don't want to ignore them.
Oh, okay.
Yeah.
Yes. So one question is about the retinopathy of prematurity, and if you have experience of, or if you are aware of any other studies that examine the oximetry in this disease. And I mean, there is a high level of retinal oxygenation. And I mean, we have oxygen therapy for ROP. So the question is here, do you have any insights on that?
Yeah, unfortunately, no, I have very little insight on that.
So we did a study, Professor Linsenmeier.
Yeah, we've not been able to measure those, but
No.
go ahead, Amani.
Yeah, we did a study with the visible light OCT in rats in that. And it's the answer is complicated, but basically as the inner neurons die, the oxygen consumption goes down. So really complicated answer. So I'm happy to send the link to the paper to the question asker offline. But Manaz had a question too. Rob, Andreas, you want to read that? So it's about light-induced metabolic modulation to prevent hypoxic damage in diabetes. So all those red light. There's a lot of photobiomodulation studies out there. Do you have any ideas about those?
Yeah, so there was thought that because light reduced the oxygen consumption of the photoreceptors, that that would allow choroidal oxygen to relieve some of the hypoxia in the inner retina. This was an idea that Jeffrey Arden and people in England pursued for a while. And from the profile measurements, I think it's just not going to be a big enough effect. There is more oxygen around in the retina during light, but when you have light, you also increase the metabolism of the inner retina, so that partially counteracts the effect. And the amount of oxygen during light that flows from the choroid to the inner retina is really very little under most conditions. So it seems like a good idea. There have also been a couple of companies that have tried to pursue ideas of that type. I think it's unlikely to make a great deal of difference.
And then there was a question about myopia and if there could be any link between myopia progression, oxygen, and light exposure.
Well, to the extent that the choroid changes in myopia, there certainly could be. It's not something we've been able to pursue or that I have any clear thoughts about, unfortunately. I think it would be complicated to look at it. You would not expect too much going on in oximetry results, and the animals that you can study with experimental myopia, we know very little about their retinas. So there are possible connections, but I would not hazard a guess.
So one of the mysteries in diabetes is that myopic patients are protected from diabetic retinopathy. So I think that's where the question comes from. Are the photoreceptors in myopia less prone to hypoxia, or is the retina used to hypoxia because the choroid is so thin and these eyes are just living in sort of a permanent So yeah, I think it's a very interesting question, and maybe your rats need to become myopic before you measure them. We need myopic rats.
Yeah. Well, I think at this point I can only model it because the microelectrode in the retina technique seems to have been finished with my retirement. So if anybody wants to take it up, I'd be happy to help you learn to do this. But it's it's pretty difficult. So I would caution you about that. Myopia protects you against diabetes. Huh. I did not know that.
Yeah, I mean it's sort of correlative literature, and I think cross-sectional studies, large databases. It seems, and anecdotal in our practices, we rarely see diabetic retinopathy in highly myopes, even if they're poorly controlled. Any other questions from the panelists, Carol or Emma?
And another question in the Q&A. So actually two questions is there are in vivo methods to measure oxygen kinetics. The audience want to know your opinion on ROKIA, ROKIA, and another also on myopia.
Well, my opinion on what, Siyu?
ROKIA, ROKIA.
Do you know what that is, Siyu?
No, I don't know what it is.
It sounds like a new technology that we're all.
Yeah, I've heard of it, but I cannot think what it means exactly. Can the questioner spell that out for us?
Dr. Babu?
Maybe like retinal oxygen kinetics imaging and analysis.
Okay.
But I see dual wavelength imaging with laser speckle contrast imaging. Well, that's according to a paper from BOE.
Yeah, I think you're right, Siyu. He spelled it out. Retinal oxygen kinetics imaging and analysis.
Yeah.
That's
I would see if Jim has any thoughts about that.
Yeah. Retinal oxygen saturation in vessel imaging, that's been around a while, and it's got a lot of relativity and variation. Speckle is a way, I guess, to in vessels look at motion of red cells. If I'm going astray, let me know here. But if they want to know something about kinetics, and we would want to know something about, let's say, if a feeder vessel brought in high oxygen into the central retina, let's say, and you were looking at a vein segment downstream of where that happened. The kinetics of the leakage of oxygen in the vein as blood flow proceeds towards the optic disc would be of interest to understand more about what the readings in the central retina really mean, more than just the saturation yellow color codes that we see. How do you get the motion of the red cells? And I'm thinking, rather than laser speckle, more like laser velocity measurements, velocimetry types of methods to get at that. And I don't know if that even comes close to answering the question that person had, but I put that out there as a way to make more out of saturation or retinal imaging of saturation.
Mm-hmm.
all right. I think
Good. Yeah.
I think we've had a very good interest And I don't see any more questions in the audience.
No, I think Dr. Linsenmeier answered everything. Thanks so much.
Okay, well, I've learned a couple of things too. Thanks very much for having me, and I look forward to another one of these sessions.
Thanks so much.
Yes, thank you so much.
Thank you.
Thank you so much.
You.
Bye-bye.